Assalamualaikum warahmatullahi wabarakatuh dan salam sejahtera. My name is Siti Nurhidayah binti Muhammad Shokri. So today I will be presenting my case study which are children undernutrition and iron deficiency anemia in pregnancy. So case study 1 is children undernutrition. So first, introduction. The patient name was Muhammad Haris Iskandar bin Fazri. His age at 4 years 4 months, Malay and male child. So the date of birth for December 2016. So the physical activity, he is an active boy, is claimed by his caregiver. So for the current medical diagnosis were underweight and wasting. For medical history, there was no previous medical history of any serious illness except for common flu and fever. So the date of referral was at 19 April 2021. Next. Okay, next is medical diagnosis. He has been referred to nutritionist for his reduced BMI for age during the first checkup after turning 4 years. Current weight and height was at 12.6 kg and 105 cm. BMI showed less for his age, which was 12.5, which categorized as wasted. The etiology of this diagnosis is due to poor diet. Haris is picky eater and he did not consume any kind of milk and tend to choose plain water. The risk factor was include inadequate calorie intake, low intake of energy-dense foods. From his 24-hour diet recall, he consumed low amount of carbohydrates, protein, and also fat. There was no past medical history and no other current illness or disease. And also, there was not any chemical data as the condition only needs dietary consultation and the intervention by the nutritionist. Diet diagnosis relation. First, Haris has inadequate calorie intake to support his growth and development. He consumed low amount of carbohydrates, protein, and also fat. Next, Haris' caregiver claimed that he always keep morning tea and also supper, mealtime, and has low intake of energy-dense foods. Next, for medication or drugs, there was no medication has been prescribed and taken as he is healthy and had no chronic illness. Next is nutritional assessment and intervention. So first, we go through the anthropometric assessment. So for this patient, we can see that weight for age is below -2, which refer to the gross chart of WHO and categorized as underweight, while height for age is in normal range. And the BMI for age is also below -2, which categorized as wasted. The biochemical and clinical data for this patient was not applicable. For physical activity status, Haris is an active boy as claimed by his caregiver. So this is the growth chart for weight for age 2 to 5 years old boys. So Haris value show below the -2, which are categorized as underweight. So height for age was categorized as normal, which the value is below 0 or median line. And BMI for age was categorized as wasted as the value below -2. Next, dietary intake. So this is the table of frequency of food checklist of Haris food intake in 24-hour diet recall. Okay, next is tabulation of dietary intake. So from this table, we can summarize that the total energy intake for Haris was 1,021 kilocalories per day from 24-hour diet recall. Next, for dietary comments identified from food habit, the estimated calorie intake based on his diet recall was total 1,021 kilocalories per day. His energy intake was below the recommendation up to 21%. This is due to low carbohydrate, protein, and fat intake in his diet as shown in 24-hour diet recall. For food and supply availability, Haris has enough food supply and availability because Haris' family is categorized in M40 family. So for the claims and complaint from the caregiver, Haris is picky eater as he does not prefer to consume milk and he always keep his morning tea and supper mealtime. Next, for behavior knowledge, attitude and motivation of patient, Haris always late to take breakfast as he wake up at 11 a.m. while his caregiver has lack of knowledge on dietary recommendation for their children at age 4 years old. Lastly, Haris does not have any disease sign and symptom that affecting nutrition intake. Next, for nutritional diagnosis, insufficient nutrient intake related to low amount of calorie-dense food intake as evidenced by the plotted Z-score growth chart of below -2 for weight for age and BMI for age WHO growth chart. So this was categorized as underweight and wasted. Next, nutritional intervention. So the objective of nutritional intervention include to assist the weight gain and reach normal score on the Z-score growth chart. Next, to provide nutritional consultation and education to caregiver on how to provide and select energy-dense foods for better increment of the child weight. Next, we go to the principle. So the principle include to follow the recommendation by Ministry of Health for children 4 to 6 years, which at least one full scoop of rice or 1% of carbohydrate sources during the main 3 meals time, and add 1 to 2 teaspoon oil to meals to increase the energy content. Next, feed child 4 to 5 times of small meals daily with 1 to 2 times nutritious snack. After that, give child energy-dense foods such as rice, potato, and also wheat. Also, encourage caregiver to provide the food that child likes more often, such as the broccoli or noodles. After that, give child at least a piece of fish, meat, and an egg for sufficient protein content, or add legumes if the animal sources is insufficient. Next, make sure to include at least 2 cups of cooked vegetables or fruits for sufficient vitamin A and C supply. And lastly, give at least 2 glasses of full cream milk with 5 tablespoons of milk powder. Next, energy, micronutrient requirement and distribution. So energy range was at 1,269 to 1,300 kilocalories per day. So we recommend at 1,300 kilocalories per day, which based on RNI 2017. Next, acceptance micronutrient distribution range. So we recommend Haris to take 55% for carbohydrate, which equal to 715 kilocalories, for fat 30%, which equal to 390 kilocalories, and only 15% for protein, which equal to 195 kilocalories. So for the exchange of macronutrients, carbohydrate was total 7 exchange, protein 3 exchange, and fat also 3 exchange. Okay, next, this is the table for distribution of exchange portion according to food groups and meal time for 1,300 kilocalories per day for Haris. Okay, next is menu planning of 3 days menu plan for 2 weekdays and 1 weekend. So this is the table for 3 days menu plan for Haris. Next, nutrition monitoring and evaluation. The schedule for the next TCA was at 30 April to monitor his weight gain and the caregiver compliance to the tips given by nutritionists. The evaluation for the case will be conducted by assessing the anthropometry and dietary intake to evaluate any positive changes and improvement from the current condition. But nutrition monitoring and evaluation was not applicable since the data of patient only got from RCP session by training supervisors. So, the data of previous and after the RCP appointment for the patient was not provided by field supervisor. Next, discussion. Wasting is often indicates recent and severe weight loss. It usually occurs when a person not had food of adequate quality and quantity, or they had frequent or prolonged illness. Wasting in children is associated with higher risk of death if not treated properly. Mostly it occurs in low and middle income countries. Macronutrient deficiencies are a lack of vitamins and minerals that are essential for body functions. Underweight children may be missing the key nutrients due to malnutrition and malabsorption, and also it can impact the development of the brain and lead to delays in developmental milestone. Next, energy requirement for underweight and wasting might be solved by feeding children with calorie-dense nutrients. In Harris cases, the main cause of this problem is insufficient nutrient intake. Thus, by simply adding 1 to 2 teaspoons of vegetable oil could be provide high-calorie foods. It could be also achieved by adding lean or red meat, milk, peanut butter, and other dairy product into Harris meal, as these ingredients are high in fat content, which is able to provide instant energy to underweight and wasting children like Harris. So, as a conclusion, underweight and wasting are modifiable if the right steps are taken. By reducing the number of underweight and wasting children, the mortality rate among children under 5 years old also could be lowered. As a parent or caregiver, we need to play an important role for our children to monitor their dietary intake in a good way. So, this is the list of the references that I use for case study 1. Next, we move to another case study, which is iron deficiency anemia. So first introduction, the patient name is Miss Kamariah Binti Ali, or known as Miss KM. She is 40 years old or female adult. Miss KM works as a secondary school teacher at SMA Mahmudiyah Kuala Berang. She holds a diploma certificate, and for the physical activity, she has low physical activity or sedentary behavior. The current medical diagnosis, she was diagnosed with iron deficiency anemia during pregnancy. Medical history, there was no history of anemia for previous pregnancy and no history of gestational diabetes mellitus during her previous pregnancy. Okay, next is medical diagnosis. Miss KM has been referred to the nutritionist since she was diagnosed with iron deficiency anemia for her lower hemoglobin level during pregnancy in second trimester on week 23rd of her gestational age. Her previous medical checkup at 19 weeks, hemoglobin level was 11.4 gm%, while her current hemoglobin level was dropped to the 10.7 gm%, which is lower than normal. Miss KM has a lower iron body store as her serum ferritin and iron show at 28 microgram per liter and 35 microgram per liter, which indicates that she has an iron deficiency. Miss KM categorized as hypotension as she has a lower blood pressure level than normal, which at 110 for systolic blood pressure and 60 for diastolic blood pressure mmHg. The etiology of iron deficiency anemia include nutritional deficiency, mainly iron deficiency, and other nutrients including proteins, vitamins, and also mineral. Also through blood loss due to menorrhagia or gastrointestinal bleeding or infectious disease and malabsorption. Next, the risk factor include inadequate and imbalanced diet, particularly low iron-rich foods intake causing to low level of iron in the body and the emergence of anemia. Besides that, insufficient dietary intake of other micronutrients such as vitamin A, vitamin B12, folate, and other minerals also associated with anemia. And lastly, she has no medical history that related to the iron deficiency anemia and no other current illness or disease. Next, for diet diagnosis relation, Miss KM consumed inadequate amount of protein and iron-rich foods, particularly from red meat, fish, shellfish, and also nuts. Next, she more likely to consume iron-based foods from non-heme iron compared to heme iron. Next, medication or drugs. At first, Miss KM takes zinc copper pills from health clinic. After that, she changed to hematinic iron tablet 200 mg together with zinc copper pills. Then the result showed the same, which is hemoglobin level was 3 drop. So, doctor prescribed her to double her hematinic pills intake from 200 mg to 400 mg taken together with zinc copper pills. But then the result showed hemoglobin still dropped. So, Miss KM has been prescribed with infferent intravenous injection since she cannot tolerate with Syncover pills and not compliant to it. The total of 4 ml of infferent was injected for 3 to 4 days in a week. Next, nutritional assessment and intervention. So, we go to the anthropometric assessment. So here, we can see the assessment of weight, height, and also body mass index for Miss KM. And Miss KM was categorized as overweight since she was pre-pregnancy. Okay, this is the table for Miss KM gestational weight gains. Next, we go to the biochemical assessment for Miss KM. So, from here, we can see the HB level was low at 10.7 gm%, which categorized as anemia. The serum ferritin also low at 28 microgram per liter, which categorized as iron deficiency, and the serum iron was also the same, which value show at 35 microgram per liter, which categorized as iron deficiency. The IBC and MGTT test was showed in normal, and also FBG was a normal. Next, for clinical assessment of Miss KM, blood pressure readings was assessed. So the indicator show Miss KM has hypotension since the blood pressure was lower than normal. Next, dietary intake. So the table show food checklist of protein intake for Miss KM. So we can indicate that Miss KM has low intake of protein since calorie intake of protein was lower than recommendation by RNI, which at 1,680 kilocalories per week. Next, the table of food checklist for fruits and vegetables of Miss KM show that Miss KM has adequate intake of fruits and vegetables since she met the recommendation from the Malaysian Food Pyramid 2020. Next is dietary comments identified from food habit. The estimated calorie from protein intake based on FFQ is total 540 kilocalories per day. Next, the estimated number of serving for fruits and vegetables was total 21 serving. So it can state that Miss KM has adequate intake of fruits and vegetables as recommended to take 5 serving per week of fruits and 21 serving per week of vegetables. Miss KM has low energy intake of protein-rich foods which below than the recommendation up to 32%. This is due to low consumption of red meat, chicken liver, cockles, or nuts, or known as heme iron. Next is food and supply availability. Miss KM has enough food supply and availability because Miss KM is categorized in M40 family as she has a stable job. For claims and complaints from patients, she loves to eat vegetables and fruits from dark green leafy vegetables such as broccoli or spinach, and also fresh fruits such as orange, kiwi, or strawberry. She also has low appetite on consuming red meat, poultry, and chicken or beef liver. So, for behavior, knowledge, attitude, and motivation of patient, she claimed that she has a lack of knowledge on dietary recommendation for protein intake or iron-rich foods. And lastly, Miss KM does not have any disease sign and symptoms that affecting nutrition intake. So for nutritional diagnosis, inadequate mineral intake, which is iron, related to low intake of iron-rich foods and poor iron absorption in body, as evidenced by low hemoglobin level at 10.7 gm% and low serum iron level at 35 microgram per liter than normal range. As we go to the nutritional intervention. So first, the objective of nutritional intervention was to assist the increases on hemoglobin level and reach normal range level more than 11 gm%. Next is to provide nutritional consultation and education to patients on how to select and consume iron-rich foods for better increment of the hemoglobin reading. So for the principle of nutritional intervention, first, increase intake of iron-rich foods 3 to 4 times in a week from heme and non-heme iron food sources. Next, avoid foods and beverages that can inhibit the absorption of iron in body, such as coffee, tea, or chocolate. After that, take a heavy meal 3 times a day for enough energy and nutrients intake. After that, follow the recommendation by MOH to practice a balanced diet by using pinggan sihat concept or known as suku-suku separuh during main meals. Next, follow the Malaysian Food Pyramid 2020 by MOH to drink 8 glasses of plain water in a day. After that, encourage to take 2 glasses of milk in a day for a good maternal and child health. Next, avoid consuming milk, dairy products, soy drinks, or chocolate drinks during the main meal. Take 2 hours before or after the main meal. Lastly, increase intake of vitamin C sources to help the absorption of iron from foods efficiently. Next, we go to the energy, macronutrient requirement and distribution. So first, we calculate for Miss KM ideal body weight, adjusted body weight, and also ideal weight range. After that, we calculate the energy requirement by using Harris-Benedict equation. So for weight, we use adjusted body weight to replace pre-pregnancy weight. So the additional energy requirements was added at 280 kilocalories per day at second trimester as suggested by RNI 2017. Next, the second method we use is quick method. Also the same, we add 280 kilocalories per day. And the energy range was from 1,800 to 1,887.5 kilocalories per day. So we recommend Miss KM to take 1,850 kilocalories daily. Next, the acceptance macronutrient distribution range. We recommend 55% for carbohydrate, 25% for fat, and 20% for protein. Next, the exchange for carbohydrate was total 12 exchange. For protein, 8 exchange, and for fat, only 1 exchange. So this is the table for distribution of exchange portion according to food group and meal times for 1,850 kilocalories per day. Next, menu planning of 3 days menu plan for 2 weekdays and 1 weekend for Miss KM. So here the table for the meal planning of first weekday, second weekday, and weekend. Next, nutrition monitoring and evaluation. The evaluation for the case will be conducted by assessing the biochemical measurement for hemoglobin level, serum ferritin, and serum iron level, and also the dietary intake to evaluate any positive changes and improvement from the current condition. Next, the evaluation of dietary intake will monitor the intake of energy and protein, and also fruits and vegetable intakes. Unfortunately, the evaluation and monitoring were not applicable since we are not monitoring the case, and this case study was given to us during the RCP session for patient by our field supervisor. Okay, next is discussion. First, lack of adequate iron in diet or malabsorption with iron deficiency anemia (IDA), which affects millions of people throughout the world, especially among pregnant women. In pregnancy, IDA can increase the risk of having a low birth weight baby and premature delivery. After giving birth, IDA can also affect mother by causing tiredness and reducing milk production. IDA is associated with caloric and protein restriction as well as deficiency intake in iron, vitamin B12, and folate. In Miss KM case, a dietary assessment showed that she has low calorie from protein intake per day. Next, adequate iron intake from animal sources and adequate vitamin and minerals intake from fruits and vegetables also necessary to treat anemia and help to increase iron absorption. The protein requirement chosen for Miss KM is 20% from total energy with 93 grams per day. The iron-rich foods, especially that comes from animal sources like red meat, poultry, fish, chicken, and beef liver, were very important in order to increase and improve iron supply to the patient. As a summary, insufficient diet and nutrient intake from energy, protein, and iron intake lead to iron deficiency anemia in Miss KM. Therefore, the nutrition intervention for IDA patients such as Miss KM is purposely to increase calorie from protein intake to restore normal level of hemoglobin as well as to replenish iron store. At the same time, a complete nutritional education related to patient's condition is required to increase patient knowledge and awareness to make a change, especially on dietary intake. So, this is the list of references that I used for case study 2, and that's all from me. Thank you.